Good morning, everybody. Just so that you know that the session is now being recorded. Just going to give it another moment for people to arrive. We'll be starting shortly. If you can ensure that your mics and cameras are switched off for the duration of the session. Thank you. Okay, I'm going to make a start. I think people will be arriving throughout the session, but the whole session is being recorded, so you'll be able to access everything later if you missed the first minute or two. Good morning, everybody. Just to let you know, the session is recording. And before I start, please ensure that your camera and microphone are switched off throughout the session. The recording is on now. It's absolutely fantastic to see you here today for this session, and it really highlights the importance of this topic area. I'm Holly Blake. I'm a trustee and fellow of the Institute of Health Promotion and Education, or IHPE, and I'm a professor of behavioural medicine at the School of Health Sciences at the University of Nottingham in the UK. I'm representing both organisations, and I'll be acting as your host today, as well as one of the speakers in the 4th Masterclass in our 2025 series, which is all about advocating for positive health, preventing ill health and reducing inequalities. Let me tell you first a little bit about IHPE. We are a registered charity and an international network for professionals in health promotion and education. Members are unified in their ambition to protect and improve public health and reduce health inequalities. The network promotes collaborative working, supporting members to share ideas, information and experience, and it provides the opportunity to unite as a single voice in support of actions designed to promote individual and population health. The benefits of joining us include 6 issues a year of the peer-reviewed International Journal of Health Promotion and Education, and permission for post-nominal letters to acknowledge membership. I'll give you a little bit more information at the end of the session, but for now, let's move on to our masterclass topic today, which is health promotion in urgent and emergency care. So we'll share with you our research and practice developments in this field, and you'll be able to ask questions at the end via the chat. I'm absolutely delighted to be joined today by 3 of my colleagues. We've got Honorary Professor and Dr. Frank Coffey, we have Dr. Emma Adams, and we have Lucy Morris, a registered nurse. So let me first introduce my colleagues with a little bit of background information. Dr. Emma Adams is a mixed methods researcher from the University of Nottingham School of Health Sciences. She's interested in the implementation and evaluation of applied health promotion interventions. As a member of IHPE, she contributes to an IHPE recognised public health degree programme in Nottingham. Lucy Morris is a registered nurse from Nottingham University Hospital's NHS Trust with a clinical background in the emergency department and a keen interest in bridging the gap between emergency medicine and public health. She's worked within the DREEAM research team, managing a portfolio of projects, moving on to become the health improvements research and education lead in urgent and emergency care at Nottingham University Hospital's NHS Trust, or NUH Trust. Honorary Professor Dr. Frank Coffey is a consultant in emergency medicine at NUH Trust, and he's director of DREEAM, which is an NHS academic unit in urgent and emergency care, which he actually founded in 2015, so it's been going a while now. He's an honorary professor in urgent and emergency care at Nottingham Trent University. He's got an international reputation in health education. Frank is driven to address the wider determinants of health and health inequities and champions interdisciplinary and cross-boundary working. And as a member of IHPE, he also contributes to an IHPE recognised degree programme in Nottingham. So let me just move to the next slide. The content of the session today is split into 4 parts. First, you're going to hear from Frank about the integrated whole system vision. I'll then talk to you about some research that we undertook that informed our approach. Emma will then talk to you about the alcohol prevention in urgent and emergency care training package that we developed. And then Lucy will share with you how this has been integrated into training and practice. And then you'll get an opportunity to ask questions, which you can post at any time during the session, during the chat, but we'll take those questions at the end. So to begin, I'm going to hand you over to Frank Coffey for the vision.
Hello, everybody. Great to see so many people online. As Holly said, my name's Frank Coffey. We can move to the next slide, actually, Holly. And I consulted in emergency medicine in the emergency department at Nottingham University Hospitals and was head of service from 2018 to 2023. And during that time, we tried to implement health promotion programs as core work within the department. So what I'm going to talk about over the next 10 minutes is to give you a flavour of that work, which led to some of the projects that you will hear about in later talks. And some of the lessons learned. And as intimated by the title, one of those lessons was how difficult this is to do without a whole system approach. Move on to the next slide, please. So those of you who work in emergency care, this is a picture that was taken in NUH a good few years ago now, that was in the Daily Mail. And I think those of you working in emergency care will recognise this scene. And this is what healthcare workers up and down the country have to work in really poor conditions, with patients overcrowding, corridor care, patients now in ambulances. And I can safely say that health promotion is really not top of the agenda for my medical and nursing colleagues working in this, and other professionals working in this environment. The irony, of course, is that one of the things that will solve this to some extent is prevention and being able to impact on the demand of people coming into the department. Next slide, please. So I can assume that most people, because you're on this webinar, will have bought into the concept that we see on this slide. In other words, that psychosocial and economic wider determinants impact on the health of our population more so than that 20% of the bottom, which is the traditional healthcare that we do in hospitals and elsewhere. And the challenge for us is, how do we, within that 20%, within traditional medicine, impact on those wider determinants in the settings? And that will requires a change of culture, obviously. So that's a big challenge. Next slide. And that's the challenge that's set out in Fit for Future in the 10-year plan for the NHS, moving to prevention from just treating illness. And that will require leadership, it will require workforce planning, it will require education of the workforce, and it will require a great deal of bravery and obviously input in terms of funding as well. Next slide. So why would we in emergency departments, when we're so busy, be worried about health promotion and prevention? So what can we do in an emergency department? Well, we know that we've got a very high patient volume. There's something like 26 million attendances in England alone to emergency departments. And we know that in that population, it's very diverse. And we see many vulnerable groups in percentages much higher than we see in the population. So the homeless, the people, domestic abuse, people who've been in contact with the probation service, all of those inclusion health groups who might not access healthcare elsewhere, where there'd be opportunities to engage in prevention. So having an opportunity to do that within the emergency department and having the facilities and the personnel to do that is really important. There's also a lot of evidence that an emergency department gives them a unique opportunity where people who are coming in with a health crisis might be more receptive to healthy lifestyle messages, for example, stopping smoking or that kind of thing. So we know that there's lots of reasons why we should be doing this within urgent and emergency settings, despite the challenges. Next slide, please. SBIRT is something that many of you may already be aware of, and you're going to hear more about it in some of the upcoming talks. But SBIRT is essentially a public health approach to health promotion, in that you're screening the population coming into an area for people who would be amenable to some of the interventions that we've talked about across that wider determinants, you know, whether it's housing or economic support, or whether it's support around risky lifestyle behaviours. The brief intervention bit is that you can do things, and there's evidence, particularly in emergency departments, that if you intervene briefly at that time, that you can impact on behaviours later, as I say, at that time when people are amenable to that. But more importantly, I think, is this concept then of having identified and screened those people, maybe given a brief intervention, that we can then refer them to services out in the community where they can have follow-up, whether that's support around things like homelessness, housing, financial insecurity, or whether it's around specific medical or lifestyle things that can be treated. Next slide, please. So we about, I think it's about 2021 that we opened this health improvement collaborative hub within Nottingham University Hospital. So this was a physical space adjacent to the emergency department. And there was great fanfare at this opening. You know, we had the people from the higher echelons of the trust, we had people from public health and many of the community groups working in health promotion across Nottingham. And within that physical space, if you go on to the next slide, you'll see some of the teams that we had working within that space. Probably about 12 people. So these were people who were working primarily within the emergency department. And you can see some of the teams that were there. So we already had Red Thread, which was a youth violence intervention program where we had specialist youth workers working in the department with perpetrators and victims of youth violence. We had funding for a year from the ICS for social prescribers, and some of them are on the picture there, who came in and would screen for people within the department who they could support, and also were referred by staff in the department, so they could really get the staff in the department really valued this, because before, if somebody had come in and they had something like, for example, an issue around food insecurity or housing, there was nobody really to refer them to. And having this facility available in the department and adjacent to it was really helpful. So we had members of the alcohol care team within the trust who were focused on the emergency department. We had the high intensity nervous service users workers. And those people working together as a team within that collaborative space allowed for a kind of a synergy and an efficiency and a real momentum around health promotion within the emergency department. And allied to that, we had Lucy Morris, who's going to talk to you later, who was a senior manager who was overseeing and coordinating that, but also working with colleagues in the trust and across the system to smooth, for example, referral into the system. And allied to that, there was a major educational program within the emergency department. So we had a consultant who had dedicated time to health improvement prevention. We had a health improvement fellow, and we also had 30 volunteers across the different professions within the department who were health improvement champions. So as I say, a really, really momentous, real momentum. Now, I'm sad to say that the vast majority of that has been decimated in the last year or two because of funding issues. And that's where, if we move on to the next slide, where it's really difficult within, you know, whatever passion and innovation you might have within a service, to do that without a real whole system strategic approach to health promotion is very difficult. So from the point of view of the whole system, there was support, a lot of support from the ICS, for example, for the social prescribers. There was support from Police Commission Office initially for Red Thread. And there were lots of bits of transient funding that was really helpful. But in the absence of a long-term coordinated strategic plan across the system, both at ICS level, within a trust, and then within divisions and directorates within an organisation or a hospital, or in the community, it's really difficult to sustain the type of programs that I've just described. So that was one of the learnings of how do we work as a system to have a much more strategic, coordinated approach. Into the next one, please. And this is an example of some of the services and organisations that the social prescribers were referring to within the system. So again, it's about that system approach of having a streamlined referral into the different organisations, and we were doing a lot of work around making that as streamlined as possible. The knowledge that the social prescribers had of these organisations was really valuable, because that's knowledge that people in an emergency setting mightn't necessarily have. So all of this kind of feeds into this approach that if you have an overall system approach where you've got a coordination and a consistency of messaging, that you've got planning for where your funding is going to go appropriately, you then get an efficiency that's really valuable. Next slide, please. And part of this whole thing, which is again part of the whole NHS forward plan, is the integration of this health promotion piece into the advancement in digital infrastructure. So, for example, those referrals that we saw, if we could really streamline those referrals and make them easy for people to do within your digital system, that can be really helpful. But there's a real challenge in that, because we know, for example, within a hospital trust, that most of the work that will be done around the electronic patient records or any of that will be very clinically focused, and people won't be in there with a health improvement prevention or even a research or evaluation frame of mind, because the focus will be on the clinical piece, and then the the kind of standards and targets that people have to approach collecting data for that. So another big lesson is how can we get in early with conversations around the development of digital infrastructure within trusts and within that link into the community and into primary care and join things up. Next slide, please. So I've alluded to some of the lessons that we've already learned. This is a pretty snapshot of some of the things that we were doing. The next slide, I think, just outlines and summarises some of those lessons. So one big lesson is, while it's great to have the passion and to plough ahead and get little small pots of funding to deliver stuff, unless that's done within the context of a whole coordinated system approach with alignment within organisations, across trusts, and with colleagues out in the community, and of course with the public and patients and with experts by experience, so that we've got a complete whole system approach with clear oversight and governance and a structured way of devolving funds to that. We saw within the emergency department, when we had that really that team that we're working with in the hub, that we're supporting the clinical workforce within the department. They were able to support them with education, but they were also there to be able to take on these patients who could benefit from referral, from brief interventions, but also referral into the services. And that combination of a specialised workforce, and as I say, there was probably about 12 people working in that workforce in the hub at the time, with an educated UE staff, could give a real momentum around health promotion. Digital developments are going to be absolutely key to this going forwards, and how do you integrate your health promotion into your digital infrastructure? And again, one of the things we learned, I think, that robust evaluation embedded from the outset in programs is really important. What we were tending to do is to try and go back and look retrospectively at programs that we put in, whereas if we can implement and work with colleagues in the higher education institutes and with other colleagues across the system to put in a really robust evaluation from the outset, that will help us, one, to show what works, but also importantly that gives you then evidence for sustaining these programs to get funding, because funding will become available for prevention in the future. So that was another big lesson, and we're trying to work on anything that we're doing now. We have this robust evaluation embedded. Onto the last slide. So I've kind of alluded, when I've been talking about the system, I've kind of been emphasising really the local integrated care system, the local community and the trusts, but there's also that whole national approach. And we know that there are lots of really good things, and I'm sure there are people online who are part of really good little projects that are happening, and big projects that are happening around the country in various emergency department, urgent emergency care centres, and out in the communities in urgent care settings. But it's not really joined up enough. So I think there's a big role for organisations like the College of Emergency Medicine or the Faculty of Emergency Nursing to and other specialty professional bodies and various other organisations to come together and join, so that we're sharing our knowledge. And I know the College of Emergency Medicine has been good in that there's special interest groups, but giving those interest groups a lot more profile as we move into an era where prevention is going to be more important. So I hope over the last few minutes I've given you kind of a context for the work that we've done in Nottingham that will inform some of the talks that will come later. And I'll hand you back to Holly.
That's great. Thanks. Thanks very much, Frank. So Frank mentioned the importance of connection with higher education and research, and we've just selected a few things that we want to show to you that give us the some of the context for one of the areas of health promotion that we focused on. So first of all, just let me swap slides. There we go. I'm going to talk to you about an umbrella review that we published in BMC Emergency Medicine. This examined the evidence on health promotion interventions that have been delivered in urgent and emergency care settings. These settings, as Frank has alluded to, are often people's main point of contact with the healthcare system, and because of this, they might provide important teachable moments for encouraging healthier behaviours, especially for people who may not engage with primary care. We systematically reviewed existing systematic reviews and meta-analyses published between 2010 and 2023. We focused on face-to-face interventions addressing lifestyle behaviours, such as alcohol use, smoking, physical activity and diet, for example. 18 reviews were identified in total. And notably, all the primary studies came from emergency departments or trauma settings, and there was no evidence found for other urgent care contexts like walk-in centres or minor injury units. I'm just giving you broad brush findings here, but most of the evidence relates to alcohol, with 15 reviews covering interventions like screening and brief advice. There were a smaller number of reviews examining smoking. There weren't any reviews looking at diet or physical activity interventions. For alcohol interventions, which there were quite a lot of, the findings are a bit mixed. Some reviews report meaningful reductions in drinking behaviour, particularly in the short term and in certain groups of patients, but benefits often diminished over longer follow-up periods. There's some evidence that alcohol interventions can also reduce re-injury and repeat emergency visits, though this wasn't consistent across studies. Smoking interventions like brief counselling or motivational interviewing interventions for smoking cessation, they showed some short-term increases in cessation rates, but again, the evidence was quite variable and longer-term effects were unclear. Overall, interventions that included motivational interviewing, so behaviour change strategies and some form of follow-up contact tended to perform better than just one-off simple advice sessions. The review also considered implementation. Delivering health promotion in a busy emergency environment is challenging. You've just seen Frank's photos, evidence of that. Reported barriers included lack of time, limited training or confidence among staff, and concerns about disrupting patient consultations. On the other hand, patients often found the interventions acceptable, and in some cases, interventions that were delivered by trained external staff or associated services achieved higher uptake than those delivered by routine clinicians in the department. Training requirements for staff did vary from a few hours to more in-depth courses in behaviour change techniques. So there's really a lot of variation in what's being offered. And this review overall did demonstrate that little is known about how best to embed these approaches into routine practice. There's still a lot of work to do around that. And the quality of existing evidence also varied widely, limiting the strength of conclusions. So in summary, this review showed that urgent and emergency care settings are a very promising but underused venue for health promotion. Although the quality of evidence was variable, there was some evidence of effectiveness, but it was notable that many interventions focused only on the brief intervention or the brief advice part of SBIRT without including the screening or onwards referrals. So that was interesting. And although several barriers to implementation were referred to, a key barrier was actually lack of training in how to deliver SBIRT. So that's a really notable thing that came out of this review, was lack of training. I'm just going to move on to the next slide now to tell you about an open survey that we conducted to explore how staff working in urgent and emergency care settings view and practice alcohol screening, brief intervention and referral to treatment, or SBIRT. This was an open cross-sectional international survey to probe attitudes, barriers and current behaviours. And the survey was online. It was accessible to staff working in any professional role within UEC, urgent and emergency care settings. It combined closed and open-ended questions to gauge beliefs about health promotion, actual SBIRT practice and obstacles encountered. A total of 362 respondents completed this survey, and they spanned 7 occupational groups. More of the respondents were doctors. We also had nurses and a lot of advanced clinical practitioners, but there were different occupational groups included. Most of the respondents worked shifts, about 88%, and they ranged in age from 21 years to 65 years. Despite the acute pressures in urgent care and emergency care settings, most respondents agreed that health promotion is part of their professional role, and they believe that SBIRT for alcohol is appropriate and is needed in their environment. Many also felt that it would be acceptable to patients. In practice, however, adoption of health promotion activity was variable. Somewhere in the region of 2/3 of respondents reported that they currently provide brief alcohol advice, but fewer reported routinely screening patients for alcohol misuse or making referrals for treatment. And that was quite in line with our prior umbrella review as well. When reflecting on obstacles, respondents cited several consistent themes. So, as you might expect, a heavy workload and a lack of dedicated funding for preventive work were frequently mentioned. Some were concerned about delays in referral pathways and patient receptiveness or resistance to discussion about alcohol use. However, one of the most commonly reported barriers was that staff felt they lacked sufficient knowledge or training in SBIRT methods, so it's training coming through again. In their open text responses, participants urged for stronger institutional support for health promotion, clearer guidelines and policies around the use of SBIRT in emergency care, appropriate spaces in which to have these conversations, better resourcing of staff or even dedicated health promotion teams in UEC environments. And of course, improved referral systems to treatment services. And there was a call for adequate training and educational materials, which we'll talk about a bit more in this session. We looked at how attitudes and practices varied by demographic and work factors. There were some differences by occupation and by region within and outside of the UK and setting, though the survey wasn't powered to offer really definitive comparisons. Overall, we concluded that urgent and emergency care workers generally support the idea of SBIRT for alcohol misuse, although there were some contradictory views. They really were in the minority in the respondent sample. People are open to playing a role in prevention, but there are real and substantial barriers to implementing it in practice. To translate intent into action, we argued that emergency services and health systems must commit to structural support through time allocation, staffing, training, guidelines and functional referral systems. And if these challenges are addressed, embedding SBIRT into urgent emergency care could contribute meaningfully to reducing alcohol-related harms and easing downstream demand on services. So conclusion. So I'm just going to move to the next final part of my talk, which is about a review we did very recently. So as health promotion educators, training has obviously come up in the umbrella review and in the survey. And as educators, it's something that we can quite easily address. To recap, SBIRT is seen as a promising approach to identify and intervene on health behaviours, but many medical and health professionals have told us that they lack the training and they lack the confidence to implement SBIRT in practice. Digital training offers flexibility, as Frank mentioned, for busy healthcare professionals. It needs to be integrated into the wider digital systems as well. It's got potentially wide geographic reach, but there was no evidence review existing that determined whether delivery of SBIRT in a digital form would be effective or not for improving knowledge, competence and confidence for health promotion, behavioural and/or health outcomes. So this is what we did. We searched a comprehensive range of databases for studies published between 2001 and 2024 that tested digital SBIRT training interventions for medical and health professionals. We found 42 articles that met our inclusion criteria with a total of almost 9,000 participants. Only 8 of them were randomised controlled trials and only 1 study was conducted in the UK. The training was delivered largely through web-based modules, digital patient simulations or blended learning approaches that combined the online and in-person approaches. Overall, this review showed us that digital training may lead to some improvements in knowledge, competence, confidence and self-efficacy. As examples, this could be better knowledge about substance misuse and its management. It could be improvements in self-reported competence, or it could be a higher reported confidence in delivering SBIRT and greater self-efficacy of the individual to engage with their patients. So that's really promising and encourages us to move forwards with this approach, but there are limitations in the published evidence. Most studies focused on alcohol, tobacco and substance use, with less attention on other health and behavioural domains, and that will be expected given our findings from the umbrella review. The quality of the evidence is variable. Many studies were observational or pre-post designs, and only a minority were robust randomised controlled trials. Across studies, there's substantial heterogeneity in who was trained, for example, doctors, nurses, allied health professionals or other, and there were differences in the content and duration of digital training, the comparison groups and the outcomes that were measured. And because of this, it's quite difficult to draw firm conclusions or reliably generalise. Also, it was notable that very few of the studies looked at staff behaviour changes in terms of whether it impacted how often they delivered SBIRT in practice, and very few looked at downstream patient outcomes. In conclusion, the review offers cautious optimism, so digital SBIRT training holds promise to boost clinicians' readiness in terms of knowledge, confidence and self-efficacy to deliver SBIRT interventions. but the evidence is not yet strong enough to confirm that these training programmes translate into sustained practice change or improved health outcomes, so that's yet to be found. Given our umbrella review and open survey highlight a clear need for training in SBIRT, and our systematic review tentatively suggests that digital approaches may be effective for some outcomes, we developed a digital training programme that Emma is now going to talk to you about. I'll just hand over to Emma.
Holly, you're taking questions at the end, all questions at the end, because I think somebody has their hand up for questions.
That's absolutely correct.
After all the talks.
Questions via the chat at the end. Thank you.
Thank you, Holly, and good morning, everybody. Thank you. Go straight to the next slide. So as Holly's just outlined, we know from the umbrella review and our other studies that there is a need to develop a training intervention to help support healthcare professionals in urgent and emergency care to have conversations with their patients about alcohol consumption. So we set out to develop a training package, and the main aim of that package was to develop and test an evidence-based digital workforce training for urgent and emergency care workers to facilitate alcohol prevention activities in urgent and emergency care settings. So I'm just going to briefly talk through the development and evaluation of our training package. So the training was developed between April 2021 and March 2022, and we used the 6-step ASPIRE process. And then we adopted a collaborative participatory design. For the first step, we held synchronous and asynchronous consultations with a virtual expert panel and members of the target audience to establish the aim and learning outcomes for the training package. So the agreed aim for this resource was to increase knowledge, confidence and skills in screening, brief intervention and referral for treatment for alcohol prevention in urgent and emergency care settings. So we then held a 2-hour online storyboarding event using Microsoft Teams, and that was attended by 22 participants. And that included the project team, multimedia designers and invited individuals, with expertise in nursing, medicine and public health and emergency services research, along with some experts from community health protection services. And this session included an introductory presentation and small group breakout sessions where we used where we asked participants to discuss 3 questions in relation to the content format of the training package, and to suggest some resources that we could signpost training participants to at the end of the training. Following on from the storyboarding, the project team undertook the production phase. So we used the information gathered in the first 2 stages to develop a draft specification for the training. And we worked collaboratively with team members and learning technologists to review and then finalise the content of that specification and select appropriate graphics and media. The specification was then reviewed by 4 times by the project team, and also we invited 10 people to review that specification. Oh God. So, and then following the further amendments to the specification, the media components were then developed and integrated into the platform, and we used a mobile-first design philosophy to maximise user experience, and that would work across all major platforms and devices. And this then went under around a second round of peer review with the same 10 reviewers, and was also simultaneously reviewed by the project team to address any final issues. The final version of the resource was then further tested for understandability and functionality with 5 members of the public, and it was released in January 22 onto an open repository, and we made it available to users by circulating the link through our professional networks and through social media. And we then evaluated the resource, which I'll come back to in a moment. So the output of the ASPIRE process was the successful development of the online training package on alcohol prevention in urgent and emergency care. The training takes approximately 20 minutes to complete, so hopefully can be fitted into healthcare professional schedules. And it includes a variety of interactive components and activities to maintain engagement. And each section is also audio transcribed to support the learning experience if that's required. Next slide, please. So this is the final content of the training package, which was informed by the ASPIRE framework and was co-produced by the participants during the development process. just to summarise that, it includes some general background on the impact of alcohol on health and the guidelines for low-risk alcohol consumption. It explains why urgent and emergency care settings are ideal settings into which to tackle alcohol consumption, and it provides practical information and guidance on how to deliver screening, brief interventions and referral to treatment to help healthcare professionals in their daily practice. There's interactive elements throughout, as I mentioned, and a short quiz at the end to test learners' knowledge and understanding. Along with that, there's an evaluation survey so that we can collect ongoing feedback from users, and also the resources section, which signposts participants to other resources if they're looking for additional information. Next slide, please. So this is just one example of one of the interactive elements of the training package to help healthcare professionals understand how to talk to their patients about alcohol prevention and raise that subject. It consists of 2 short videos with the nurse talking to the patient using 2 very different approaches. The first video shows the nurse going through the screening process using a validated tool with regards to the patient's alcohol consumption, and then talking to the patient about their alcohol consumption, asking about if they've thought about the impact of their drinking and if they had considered cutting down. They also then offer a leaflet with further advice, and this is done in a very compassionate and supportive way in discussion with the patient. In contrast, the second video uses much more of a telling off approach. So for drinking too much alcohol, little discussion and support with the patient, and just advises the patient to take the leaflet on the way out in a very abrupt and uncaring manner. So participants completing the training are asked to reflect on the 2 videos and note down their thoughts about how the 2 approaches differed, what went well, what could be done better, and how they might do things differently, so to help them think about how they might apply this in their day-to-day practice. Next slide, please. So then the final stage of the ASPIRE process is the evaluation. And through our evaluation, we aim to assess 3 questions. So the perceived relevance and usefulness of the training package, whether it improved users' attitudes, knowledge, confidence and skills for SBIRT, and whether the training package can contribute to facilitating health promotion practice around alcohol prevention in urgent and emergency care settings. Next slide, please. So we evaluated the training package using a mixed methods approach, and the evaluation was mapped to the Kirkpatrick model, which is a commonly used approach to evaluating the results of training and education programmes. And we assessed the first 3 levels of the Kirkpatrick model in our evaluation. We used the quantitative data, which was collected from 19 users via the 18-item survey, which was embedded into the training package. And subsequently, the training package was delivered to a convenience sample of 18 healthcare professionals as part of a training day for healthcare improvement champions at a large teaching hospital trust in England. And of these participants, 15 agreed to take part in an interview where we did some more in-depth evaluation of the training package. Next slide, please. Now, findings from that showed that healthcare professionals were highly satisfied with the training. They found it easy to use and accessible, and they rarely had any technical issues with it. They found the materials engaging and enjoyed the interactive elements, and they perceived the training as relevant to themselves and others. And they said they would recommend the training to other healthcare professionals. The training was thought to improve perceived knowledge, skills and confidence for using SBIRT, particularly for those with less experience of health promotion in urgent and emergency care environments. And it was thought that positive attitudes towards health promotion and SBIRT were reinforced. They also reported behavioural intentions to use SBIRT in the future. So overall, we successfully developed and evaluated a training package for urgent and emergency care workers to facilitate alcohol prevention in those settings. So just to finish off, this is the details of the paper where you can read more about the development and evaluation of the training package and the link to the actual training package itself. And I'll pop both of those in the chat at the end of the session. So thank you very much. I'll hand over to Lucy.
That's fantastic. Thank you, Emma. Over to Lucy.
Thank you very much, Holly and Emma. So as we've already covered so far, and we've looked at kind of the strategic position of health improvement and prevention within emergency medicine, and then Holly and Emma have also taken us through that evidence base and the development of the reusable learning object, the online resource. So I'm going to talk a little bit about what that looks like in practice. So next slide, please. So firstly, there are some key barriers, as we've really discussed so far already, around delivering education within emergency departments, particularly on these topics. So we do have over 500 members of staff working in our emergency department, many of whom we think it's probably about 30% are in rotational positions, so they aren't with us very long. And also we do have quite a high turnover of staff within the department, just due to the nature of the work. So this does mean that it can be a challenge. So one of the key things that the research that we've done with Holly and Emma over at the University of Nottingham has given us that evidence base for the need for education within this space. And this has also supported a bid to Health Education England for a health improvement and prevention education fellow, and that's Laura Walker, whose picture's on your screen now. So Laura was in that post for just over a year, looking to deliver education within the emergency department on health improvement and prevention, and this was really key. Next slide, please. Back one, sorry. So Laura and myself developed an education curriculum within this space, and there were kind of 4 key elements to that. So the first one that has been mentioned was our health improvement champions. So these were dedicated members of staff with a short amount of time. I think it worked out about half a day every quarter, so it really was minimal. But it meant that they had a role as a health improvement champion within the emergency department. They did receive some additional training, and they also were staff that were already quite passionate about this subject. And they were able to support us with education delivery, providing messaging. We had a WhatsApp group, we'd shared podcasts or relevant information that was going on within this space, any new guidelines. And this was really key to try and building up some momentum within the department. And it was really achievable, like I said. So I think there was just under 30 members of staff, and they had 4 hours every quarter. So it wasn't a significant impact on our emergency department rota. Next up, we have the online learning resource that Emma has gone through already, so I won't dwell on those. And then next we had our high fives, we called them. So this was a clinical area teaching model. So it wasn't realistic for us to take members of staff out into our teaching areas for kind of long education sessions. And we also know this probably isn't the most effective way of delivering education when we wanted something that is going to be very clinically based. So either myself or Laura or one of our health improvement champions, if they were available, would go out to our emergency department every morning, and we'd do a 5-minute teaching session with 5 members of staff, and we'd do that 5 times a day. And in turn, that meant that we were reaching 500 members of staff a month with different kind of health improvement and prevention priorities. So it might be that we'd focus on smoking one week and alcohol the next, but it did mean that we then started to build up that momentum and really started developing those conversations within the emergency department around health improvement and prevention. And finally, the little logo on the right there represents our online learning resources. Our online referral resources. So it was really important to us that whilst we're having these conversations, one thing staff were really struggling with was knowing where to send people to. So we were really fortunate, as Frank mentioned, to have the Health Improvement Collaborative Hub with those teams there, but they weren't always available. So we had to think about out of hours, we had to think about weekend working, and we also needed to think about those patients that didn't want to wait in the emergency department to see one of our services, but could still benefit from that follow-up support. So we created a patient-facing website, and there we had a list of lots of local resources that were available to receive referrals, either through ED staff or through our Health Improvement Collaborative Hub. And this was really supported. We knew one of the key barriers for staff, they didn't want to have the conversations around health improvement and prevention topics because they just didn't know what to do with the information. So this was really key. Next slide, please. So these things together created a really positive momentum within the department. So we were receiving over 100 what we called hits, so people accessing the online patient resources. We saw a real increase in staff confidence when speaking about health improvement and prevention interventions. This was particularly around knowing where to send people to. And also for those teams that were working within our hub, we saw a massive increase in the number of referrals that they were seeing. Interestingly, the kind of services that saw the most improvement in referrals were ones that were based in our emergency department. So, for example, we didn't have an on-site resource for smoking. They were using an online referral out into community services. So it was interesting that actually those places that saw the significant increase were people they could refer to on site, and actually having those staff available really increased that momentum. It also meant that we could start offering placements to GP trainees working in our children and young persons emergency department to come and spend some time with us in the hub and do some projects. And they were able to do some fantastic work around food insecurity and education, also around high intensity service use within children and young people's emergency medicine. So it also created more research and opportunities for further evidence to be developed. And I think the key part of this was really creating partnerships with community organisations. That's one thing we felt quite isolated as an emergency department. And as Frank mentioned, this really is a systems approach. So creating those relationships with community partners really was key. I think that's all of mine. So I think we're free to take any questions now, Holly.
Fantastic. Thank you very much, Lucy. So I hope you enjoyed those different presentations. We've got time for a few questions, which I'm going to take from the chat. I'll finish off the end of the session by giving you a little bit more information about IHPE, but for now I'm just going to field a few questions. So what somebody has mentioned here, one of the problems is the time it takes to complete onward referrals. Do you have any suggestions for streamlining these? Perhaps Lucy or Frank will be able to answer that one.
Do you want me to answer that one? I think it is a real challenge. One of the key things that I think we did mention was around trying to make sure that we are doing online referrals where possible into community services. If we can try and make sure that these are linked in to our electronic health records, it can mean that those processes are much smoother, rather than going into separate websites to refer to individual services, if that makes sense. Trying to build them into your local electronic health record can be helpful. And also, as we mentioned, the referrals are much easier if there are staff on site, because then it does just become a simple phone call, knock on the door around to the office, and it creates much more of kind of a personal relationship with those services that can help also with increasing referrals.
Thank you very much.
Yeah,
we
I
haven't
just
add
I
anything,
think,
Frank? Yeah.
yeah, just the other thing is, if looking at it from a systems approach, if it's easy, if there's a more central integrated kind of service hub that you're referring to one place rather than looking at lots of different services, so that if you've got one place to go to that then can look at the referral and refer to the appropriate place, that makes it easier for the staff at site referring out into those community services, as well as the things that Lucy said.
Brilliant, thank you. We have a question here. Do you have any plans to adapt the online digital training package that we made, the alcohol prevention package? Any plans to adapt it for wider use, such as primary care? Frank or Lucy?
We don't at the moment, but I think there's a lot of the principles that are in that package already that would be relevant to within primary care. So the generic principles about SBIRT and the types of conversations, I think, would be transferable to the primary care setting. Lucy, anything to add to that?
No, I don't think so.
Yeah, I think that's quite key, because when we did the review work, we did notice that there was a lot of SBIRT training available, but it was generic. And one of the benefits of this particular digital training was that we made the scenarios unique to urgent and emergency care. Yeah. Emma, do you want to add anything there?
I was just going to say there is some more generic training available through the e-learning for health system, but yeah, we tailored ours obviously to the specific setting. So yeah, there is some generic training out there.
Thank you very much. Another question, did you manage to gather any data to demonstrate the impact on emergency department attendances and or use of other healthcare teams, such as primary care? Any of our clinical colleagues for that one?
So the answer is no, we haven't, and that's part of one of the challenges, I think, about getting that robust evaluation in from the outset when you're introducing services, because it's incredibly difficult to do that retrospectively. We have now a severe multiple disadvantage practitioner working in the emergency department, and we're starting to see already some benefits already in terms of reattendance and length of stay and stuff like that in hospital. But we really have to have much more robust evaluations embedded from the outset, I think, to look to sustain funding for these projects.
I think I'd agree with that. I think there's a lot of scope here for further research, well-designed research from the outset, and that was very clear from the reviews and the minimal number of randomised control trials, which, as we know, are quite difficult to conduct in these very busy, fast-paced real-world settings, but there's certainly scope for that. So I have some more questions here. I just want to read out a contribution from one of our international colleagues that's joined us today from Nigeria. Health promotion in urgent and emergency care settings is often overlooked because its environments are fast-paced, focused on acute care and resource-stretched. However, UEC offers a critical touch point for health promotion because it reaches people who may not regularly access primary care services. Yes, many patients present with conditions linked to preventable risk factors such as smoking, alcohol misuse, poor diet, sedentary lifestyle, or mental health crises. Yes, again, that really hits the mark for what we found in the survey, both from colleagues within the UK and outside of the UK. Frank, do you want to add any comment on that?
No, and thank you for emphasising those points. I think you're absolutely right.
Yeah, thank you for that. So we've got a question here. NHS North of England, we're keen to develop social prescribing in UEC as part of our NENC DPEN network. Would be very keen to speak with colleagues with experience of this, if possible. Just for everybody's information, we'll be collating some of these comments and points, and they will be shared with everybody as well via the IHPE, as will the recording from this session. So you'll be able to access this information, as I'm aware that some of you don't have access to the chat. So we have a question here. How do you keep the online referral resources up to date? What resource does that require?
Do you want me to take that one, Frank?
Yeah, Frank or Lucy.
So actually, now that the resources are set up, it hasn't taken as much resource to maintain them. I know one of the challenges is the fact that a lot of our community resources are changing due to funding streams. So it does need someone to keep a bit of an eye on it. We were fortunate that our social prescribers used a lot of the existing mechanisms that they had developed to try and help us implement these before the pilot was unfortunately finished. So it did mean that we had some resource there to start with that initial setup, and then onward kind of referrals if we've just set up an arrangement with those places to let us know if anything does change and we need to update things our end. It has also coincided that we've had a lot of changes within our emergency department in the way in which we use our electronic health records. So we have had to make quite a few changes just because other things are being updated. But if that wasn't the case, I don't think it would take too much to maintain.
Thank you. I've got a question. I'm going to pivot to Emma here. Was the digital training co-produced with service users or patients? Were any involved in the digital training?
Yeah, so in addition to the healthcare professionals and academics that were involved in the training, we had a couple of patient service users who contributed to the package and also were involved in the co-production and reviewed specification. So, yeah.
Fantastic. And moving on from that same person, is there a need to develop training packages for each health promotion topic? In my view, as an academic, yes, because we conducted the umbrella reviews, really clearly demonstrated that there was a focus on alcohol and substance use, misuse, and less focus in other areas, some focus on smoking. But also it was quite interesting in the online survey that we delivered that many of the respondents said they'd be receptive to health promotion topics such as mental health, diet, physical activity, all sorts of areas. Do you want to add anything to that, Emma, or are you happy with that?
Yeah, no, I agree with what you said. I think obviously there's some general principles around delivering SBIRT, but yeah, some specific training packages on specific health promotion topics I think is really important to highlight those areas. So yes.
Ongoing theme seems to be scope for further research, I think, definitely.
Yeah.
And again, we have another question. This is quite a challenging question, actually. Is it ethically justifiable to prioritise preventive health promotion messages in an emergency context where patients may be distressed and focused on immediate relief? Frank?
I mean, clearly your initial management of the patient who comes in at death's door is on the immediate medical management of those patients. But as we know, there's, a huge number of the patients that come through emergency department doors where that kind of distress is there, but actually maybe, as I said in the talk, makes them, and I think you mentioned as well, makes them receptive to messages around healthier living. And I think it's certainly ethically justifiable to improve patients' health by having conversations and directing them for that. But it can never be the primary work. The primary work in the emergency department will always be that clinical bit at that high-end management. But as we see, there's the challenge is how do we integrate health promotion and the opportunities for health promotion in an emergency care setting, which indeed is ethically justifiable, I think.
Wonderful. We've got a comment here from a colleague who says, we've commissioned our third sector substance use, drugs and alcohol provider to work in the emergency department to complete SBIRT. Initial findings suggest better ongoing engagement with services, having been seen by the service itself in the EU, which is really great to hear that, and thank you for sharing. We've got another question here. You mentioned follow-up is important for sustained behaviour change. How do you link up with primary care? Is there any linkage at the moment with primary care?
So I think I'll let Lucy comment as well on this. When we initially set up that health improvement hub, we set up what was called an urgent and emergency care collaborative, which was a kind of governance over the hub. But we had representation from primary care on that, which is starting to make those links across the system. And this goes back, I suppose, to this whole system approach and how we're linking in with the integrated care board and the integrated care system to create structures that allow that conversation both ways to happen. The communication, the referral, the sharing of information. We've just done a health needs analysis on the population attending ED to start looking at where we might be able to intervene, but also kind of sharing some of the data in primary care sources as well to look at where that linkage can be made. So I think the point is it's really important that communication is there and that follow-up and forward and backwards between primary and secondary care is really important, I think. Lucy, have you anything to...
I guess just on a practical level, a lot of this information was included within our ED discharge summaries that goes out to GPs, which we know isn't a perfect system, but it does mean that information was shared from us through into primary care. Also, our social prescribers were employed by organisations that also did some social prescribing within primary care, so they almost acted as that link as well, and could refer through into PCNs and PCN social prescribers to try and ensure that we didn't have anyone falling between the gaps.
Thank you, that's great. We've just got time for a couple more questions. So we've got one here. Is there expertise in past trauma feeding into the interventions, for example, that underlying alcohol and drug misuse?
Well, we start certainly in the emergency department. We've now got clinical psychologists working in the department who are keen to support our SMD, severe multiple disadvantage person around bringing in introduction education on trauma-informed care. So certainly in this department, that's a key element. And I think a lot of this is looking at the way we've treated these groups coming into emergency departments historically. And there's a lot of lack of understanding of why people have ended up in those situations. So I think that's part and parcel of the whole educational programme.
It's wonderful. I've just got one more question here. So is the digital training that we made, is it suitable to be used in other regions or trusts? And I'll let Emma answer that one.
Yes, absolutely. And I'll post the link to the training session in the chat in a moment.
One thing that I do want to make clear is that the links to all of our papers and the link to the digital package for use elsewhere will be shared with everybody that's registered. So you'll get access to that, and the recording and all of those papers will be linked into the IHPE website, so they'll be available as well. So I just want to confirm again, the recording of the session will be available on the IHPE website in due course. So if you did miss the beginning of it or any part within due to a dropout of technology, you'll be able to catch up on that. You should have received the information already by email, but if you'd like to attend the next Masterclass event, you can find out more and sign up at the link, which I'm just going to put up on the screen there now. So there'll be information in the emails that you've had from IHPE, but also there's a link here where you can sign up and register for the Masterclass. IHPE always welcomes new members, so please do take a look at our website and consider joining. There's currently a £10 discount, so if you join now, that covers the rest of 2025, but it also covers the whole of 26 as well, so you do get a bit of a discount with membership there. And finally, please do fill in our one-page evaluation survey for this session. It literally only takes a minute, but it really helps to shape our future activities and see what's beneficial. And you've got an opportunity to suggest topics you'd like to see in the future as well. And you can complete that via the QR code here or through the link that will be emailed out to you. Once again, I extend a huge thanks to my colleagues, Frank Coffey, Emma Adams and Lucy Morris for sharing their expertise with us today. I hope you enjoyed this session. We've come to the end now, so we'll see you next time. Goodbye.